Our next talk is on gut resilience and how probiotics strengthen microbiota and fight diseases. I would like to call upon our expert speakers, Dr. Sridhar Ganpati sir and Chairperson Dr. Praveen Gokhale sir, to enlighten us with their expertise.
Thank you so much, Tana Association. Thank you, Praveen. Thank you, Sanofi, for giving me this platform. And I just understood one thing from the cacophony, that it's human to err and more human to point out mistakes. And I just thought I would add on some more because drugs are something very close to my heart. I just thought the IPF should have come pretty early in the diagnostic profile. And I thought levetiracetam itself can bring about platelet dysfunction. So if you start bleeding after levetiracetam, it can cause that affection of thromboxane-induced platelet dysfunction. Adding a topiramate, I was just wondering, just a few convulsions, why add a topiramate, which has the same potential to bring down thrombocytes. So each one looks from his angle, and the medicine is thoroughly complicated. So I'm talking on a Sanofi platform, and I would be talking more on a probiotic called Bacillus clausii. But the purpose of the talk is to understand that I am more of a microbe than a human being. And I need something called as a cohesive synergy between the microbes that I carry and the human system. So what I'm trying to emphasize on is a new theory of sustaining evolution. So it used to be what was called as Darwin's theory of evolution, survival of the fittest. It's no longer that. It is survival of the one who can adapt and adjust the best. And we all do know that very well today in life. So when I talk about probiosis, because we are now running short of antibiotics, we are looking at microbes as therapy or bacteriotherapy. We have now started realizing, since the microbes they are much more than the number of cells that we carry, we need to sustain them. And it's a bidirectional sustenance. They provide many things to us, and we provide many things to them. And as long as you sustain a good microbiota, you do well in health. And most of the microbes that we carry are healthy ones. Microbiology is changing. We don't look at a microbe in the petri dish. We now know it's a community out there. We don't look at an organism as a pathogen. We look at them as a perceptogen, the way the immunity looks at a microbe. So I could be carrying a staph in my nose, and I'm called a carrier. I have a child in my ICU who's got a necrotizing pneumonia. The same staph is creating havoc out there. So everything seems to be changing, and now we have started understanding our bugs, and we need to respect our bugs. I'm just going to run through these slides because the main reason why I'm standing here and talking to you about probiosis is the market is full of probiotics. And you have every probiotic. You have a probiotic which is generic. You have a probiotic made by a local manufacturer. You have a probiotic made by a big company. And you need to know what to prescribe and how to go about probiosis. So when I look at a probiotic, start looking at a probiotic as a drug. Don't use it as for hair growth, for fairness, for better oral hygiene, for heart, for obesity. Start looking at it as a drug. Know the indication, know the dosing, know the interactions, know how to give it. And the most important thing today is we are even using it in the NICU. And there was a time when we were scared of bugs, the COVID time. If I had to disperse of this crowd, I just had to keep coughing and sneezing. But now we are not bothered. We are using all types of cocktails, even in the prevention of NEC, just with basic data, because we do know that microbes play a role. So the thing is, a bug has a potential to translocate. And if it translocates, you end up with a disease. And can you manage the disease? So whenever you use a probiotic, know the antibiogram of that probiotic. So if I'm going to be using clausii, I know most of the antibiotics that I use in the pediatric age group, it's resistant to it. So I can use it even when I'm giving the antibiotic, be it for dysbiosis, for an antibiotic-associated diarrhea, for a dysentery, for a viral diarrhea. But if it translocates, I should know what is to be given. So you have a Saccharomyces which gets into the body, I know my azole works there. A lactobacillus gets in, I know the penicillin works there. And if it's a Clausii, I know quinolones work there. The only problem with Clausii is they are spores, so you can get recurrent bacteremias. So a prolonged course of therapy. And your microbiological lab should have the facilities to pick up the organism. So if they don't have the facilities, you don't know how to pick it up, you don't have an antibiogram, you have to think twice. So today, it's very essential for you to know that. And what I mean by indication. So if I'm going to be using a probiotic, say, let's take, for example, Ruteri. I know specific indication, infantile colic. But the problem with an infantile colic, by the time you come to a definitive diagnosis, the colic is gone. But you have a mechanism of action. It produces something called as ruterin, which will block the pain receptors or the TRV channels that take pain. And by modulating this, probably you may have a role even in putting a full stop to functional GI disorders later on in life. So it's so very essential for you to know the mechanism of action. Just like if you're going to be treating an antibiotic-associated diarrhea, or you want to prevent an antibiotic-associated diarrhea, and let's take C. difficile, which is the most famous out here. If I'm going to be using Clausii, I need to understand that Clausii produces proteases that can destroy toxin A and toxin B. So mechanism of action. Then comes dosing, because the intestine has 10 raised to 12 to 10 raised to 14 microbes per gram. So when you look at a stool report and you have a stool report which mentions bacteria 5+, and it's in red, it's scary. And the patient comes running to you, showing you the report. You need to understand that by weight, stool is 50% microbes. It's not just bacteria. You have a virus, you have a fungus, you have protea, you have archaea, you have prions, and the new ones are the asterisks. So there are so many new things coming up. And we still know they are there, but we don't know who's there. So what you need to understand is one, mechanism of action. Two, in case it translocates, because we are now in an era of bioterrorism. And you need to know all about your product, because there is no regulatory body which is regulating probiotics. Most of them come into the market as functional food supplements. So this is very, very important. And then you have a cocktail. So you have people who come and tell you one versus many. But when you look at anything, so if I look at the Tana organization, I would love diversity. Because you work better. So you have somebody who's good in accounts, somebody who's good in management, somebody who's good in organizing. That makes it better rather than all belonging to the same category. Same thing with the gut. If you have a diverse population, you do extremely well. So when it is diversity, the question is, why not a cocktail? But like I told you, you need proof. So you have to ask the company, do you have any proof? And for proof, you need to know what are the organisms that you carry, what is known as enterotype. So based on my enterotype, I decide on my cocktail. So when I give a cocktail, it should be beneficial. And how is it beneficial? With specific actions or non-specific. Because most of these microbes are responsible for generating a lot of short-chain fatty acids. Extremely beneficial for metabolic activities, extremely beneficial for barrier integrity and for colonization resistance, bringing down pH, stopping the pathogens from getting in. And so you need to understand what you are using, why you are using, and for what you are using. So how do you go about quality? So for quality, you require a good regulatory body. So what was done is, this is sometime way back in 2016, and I had the privilege of sharing the stage with Professor Morelli, who's a microbiologist from the European Food Association, a fantastic fellow, very knowledgeable, all into research. And what we did is we picked up a few brands of Clausii from the market. This is the Indian and the Pakistan market. And the names have all been put up there. And what we found is there is so much of a disparity between what is there on the label and what is there inside the bottle. Then came the Indian study in 2018. This was in the Indian pediatrics, and this was by Yadav and his group. And they again picked up a few clauses from the market. And again, the disparity between what was there on the label and what was there inside. And this is not a problem just restricted to our continent, to our community, to India. It's all over the place. Because we need something called as GRAS, or generally regarded as safe. We require something called as GMP, or good manufacturing practices. And as long as you have the right person in the right place, anything and everything can be passed. And this was done by Dr. Dhanashekhar. I think you must have all heard about him. Very passionate about probiotics. He's a pediatric gastroenterologist from Chennai. He picked up a number of probiotics from the market, and along with his team of microbiologists, we have Anusha, Idya. They did both the types. They did the conventional type of culturing as well as the new generation sequencing. And just see the disparity of what is there on the label and what is there inside. And why am I trying to stress on this? The latest article from the dairy industry, because now the International Society for Pro and Prebiotics have come out with some big statements. You won't find any more a dahi with added probiotics. It will only be a dahi with beneficial microbes. Because to use that terminology, probiotics, it should be substantiated. So when you talk about the dairy industry, they picked up a lot of these dairy products with added microbes, and they found that they add tremendously to the resistance pool that you carry. And here we are talking about antimicrobial stewardship. We are talking about restricting our use of antibiotics. And we are getting our resistome increasing in size from the food that we take, the water that we drink. And I all assume that you must have traveled towards Hyderabad, Secunderabad. There is a train which goes first to Hyderabad and then back to Secunderabad, and you come across the Hussain Sagar. The Hussain Sagar at times is fully covered by the flora that it has, and sometimes it's seen very well. And when they did a level of ciprofloxacin in that water, it was phenomenally high. So it's the animal husbandry, the water, the food, the things that you take like the dairy industry, and there are so many that you get in the market. You just feel, oh, they have prebiotics, they have probiotics, whereas the common sense will tell you, stick to your diet. If you stick to what your grandmother gave you, and if you're a South Indian, you stick to your South Indian diet, you do great. You're a Maharashtrian, you eat your Maharashtrian food. But the unfortunate thing is, if I start eating or binging on Rajma Chawal, I'm going to be noisy in the night. Because I need to understand that 60% of my digestion is by the microbes that I carry. Almost 80% of the protection is the microbes that I carry. Colonization resistance, bacteriocins that they produce, stimulation of the gut-associated lymphoid tissue. And the easiest way to enter into your body is through the gut. One line of microbes, one line of epithelial cells, and the big gullet inside. So all the mischief can easily happen through your gut. So you need to understand that if you are going to be using, just see the disparity between what is there on the label and what has been analyzed. It's scary. And it's really scary. And this is, again, this came out in 2020. My friend did get a threat. He was under protection for some time. So coming to the main part of my talk is, this is an in-house study that was done by Sanofi. They picked up some of the brands that are doing extremely well as far as Clausy, because it's a usual tendency for all of us. See, you need to understand, Clausy started from 0 to a 200 crore market. The market grew because of the word of the mouth. We didn't have enough studies. None of the world bodies said, start using Clausy. There were only studies on Helicobacter pylori and the use of Clausy in Espagan, Naspagan. And now we are seeing that in our country, the market has grown so much. It's not just because I'm getting incentives that I'm writing it. It's working. Ease of administration, no taste. The only unfortunate thing is, in our busy OPD, we don't tell them that you need to shake before you give. because all the spores are seated down and you're giving only the supernatant. It's almost like a calcium syrup, where you need to shake all these suspensions. So it may not work. Ease of administration and the psychological impact. The patient feels, "Are injection pila raha hai." And they have already taken it before they come to you. So naturally you have got so many companies. I think there are about 80 plus brands other than the Enterogermina in the market. You have places in Telangana, you have places in Pondicherry, you have places in Uttaranchal, all manufacturing. There is a UBCC, and each one is called Clausy, and Clausy has come from Subtilis. So there is an admixture of everything with total confusion. So we picked up the top brands and we studied it. I won't go through the details of the study, so we could have some time for question answer. And we looked at the strain. So we naturally know you have a tetracycline, a chloramphenicol, a novobiocin, streptomycin, rifampicin, resistance strains, so 4 different strains. And when you pick them up, you can very well see that the first one is, the data is what is extrapolated in all the other strains. And they are all different. And the last one is a biosimilar. Okay, it's a biosimilar which is made here, that is the Bifilac Clausy. And they all have a big market. There is one which had nothing in it. It was just a sweetened water. Huge market. Unbelievable. You should not have, how do you sterilize a bacteria? So when you have a bacterial solution, to sterilize becomes almost impossible. So you need to have the right techniques of culturing, adding and preparing. The disadvantage and the advantage is both spores. So in our country, if you see, the spores survive the best. Bifidobacterium, lactobacillus, extremely susceptible to temperature changes. Packaging is important. Manufacturing process, very important, because if you take a lactobacilli, most of its activity comes from the pili. And the pili, to be preserved, you require a process called as pigylation. If that is not done properly, you lose your pili. And if they don't live and they are a dead organism, today we call it as parabiotics. They still have effect because they stimulate your TLR, but they don't manufacture any metabolite. So you're not manufacturing any metabolite, but you're stimulating the toll-like receptors. And one of the ways you try to control NEC is because there is an upgradation of TLR4. So you get pathogens, you get an inflammatory cascade. Whereas you give the right organism, you elevate TLR9, TLR4 is subdued. And you look, you should not have things like Shigella, Salmonella, Listeria. And see what all is there. There is a Pseudomonas. The Bacillus cereus is used as a probiotic in places like Vietnam. But what is important is you have to show that they don't produce the toxin. We all know food poisoning. The emetic toxin comes from Bacillus cereus. You can even have an eye affection. You can have severe effects with Bacillus cereus. You have a Pseudomonas there. You do not know what resistant genes they can transfer. Today the problem in all ICUs are Pseudomonas. And we don't have drugs. And even the new ones that are coming in which work on the ion pathways or on the porin system, they all have generation of resistance which is very rapid. Then you see Acinetobacter also there. So it's scary. And then you go a step further. What we did do is we tried to find the count. Like I told you, you require a significant count because the intestine has 10 raised to 12 to 14. And if I just drop one organism, it's not going to have an effect. You need to supply to the gut a significant number of organisms. There is another strain of Bacillus clausii, which actually hit the market for adults initially. And there was just one study on 32 patients. And then it started coming into the market and started creating its own niche under the umbrella term of Bacillus clausii. So that's why we have put it up here. So you require a certain amount of organisms. And like I told you, every probiotic has a number. So you ask them for the repository number. The repository number is, they are kept in a museum or they are kept in a forum where the genetic stability is studied. So you have a GG there, it is ATC 53103. You have a Ruteri, which has another number. The Clausey has it. Everybody has a number. If there is no number, it's questionable. Even there is an Indian repository in Chandigarh, so which will come with a C. So you have a douche, you have an American type culture, ATC is American type culture collection, and you need to look at the number, the genomic stability. Without genomic stability, the moment, see, you look at me, the moment I go home, I'm a different person. In a conference, I'm a different person. With my friends, I'm a different. When I'm playing, I'm different. So the same way an organism can mutate the moment you put it in the mouth. The moment is exposed to air and moisture. And that is why you have to be very careful about what you're giving. So the dosing is important. And if I say you need to take 2 grams and your preparation just has hardly 0.5 grams, the dosing becomes much more. Like I told you, your lab should have facilities to pick up the organism. You should have the facilities, because you need to know the resistance profile and you need to know what antibiotics work in case they translocate. Everything has translocated. Saccharomyces, GG, Bifidobacterium, Clausey, they have all translocated. So now we have a Boyle's criteria for safety. So if you have a line, a catheter line, you have immunosuppression by drugs or you are immunocompromised. If you are being treated for burns, if you are, so you have these Boyle's criteria wherein you wouldn't use a probiotic, and if you are going to use a probiotic, it's after a 1:1 talk with the relatives and a consent form. So even in the neonatal period, you need to have consent, you need to show them results, you need to have a 1:1 talk, your lab should have all the facilities to pick it up, and you tell them that translocation by a known organism is better than translocation by an unknown organism. Fine. So the basic purpose of me being on this stage is to tell you, look at the repository number, know your antibiogram, know the indication, know the dosing, treat either as specific treatment or as a cocktail to improve health. And just don't give a probiotic for the sake of giving a probiotic. The most important thing that all probiotics do is they generate butyrate, propionate, acetate, lactate. Everything. So when I come out of the mother's womb, it's the streptococci, the staphylococci that get in, the enterococci, they produce lactate. Acidic environment. So pathogens can't get in. Later on, it's the bifido and the bacteroids. They produce acetate. There is cross-feeding. You get your butyrates also. Again, the acidic medium is maintained. And then you get your butyrates. And there is a proportion of butyrates to propionates to acetate to lactate. So we are now into an era where we are thinking of postbiotics, metabolites produced by probiotics, because there is no question of translocation. So things are changing in the probiotic field, and my main purpose of talking today is to tell you that the next time you wish to write a probiotic, suppose I'm going to be giving Clausey for loose motions, which is viral, I have papers on what is now known as artificial intestine or chyme. I have enterocyte lines on which I have studied my Bacillus clausii, and I have a mechanism of action. Why do I fail in certain viral diarrheas? Because you need to give it as early as possible, not after there is complete denudation of the mucosal area and you also have a secondary lactose intolerance. Now this was another how much time do I have? 6 minutes. That's great. So this is another study that was done, an in vitro study, picking up the common probiotics in the market, and came in 2024. It's called the Pellegrini study. And they did a in vitro study, like we have artificial intestines today called the chyme and modified chyme. We have enterocyte lines made out of cancer cells called the Caco cell lines, and studies are done on this. And what we need to know is, it's right, you're giving a probiotic. Does it survive the transit into your gut? That you need to know. So, can it survive? And suppose I take a Clausey For how long does it remain in my gut? 10 to 12 days even after I stop dosing. 2, if it survives the transit, it has to go through acid, through alkali, through all the enzymes. And I need to show it's still there. So they do such studies to show survivability. Second, once it survives, does it get attached to the mucosa? Because you are not just interested in intraluminal, you also want mucosal effects. So in an aerobic medium, in an anaerobic medium. So they study adhesions in anaerobic and aerobic. And you see again how Clausy seems to outscore the others. So it has survivability, it has binding to mucus, both in aerobic as well as anaerobic condition. The second thing we are all interested in is, when you have a viral diarrhea, the second phase of diarrhea, what we call as secondary lactose intolerance, you need something to take care of that transient period. So we have a lot of modifications of diet. We change over to dahi and buttermilk and chas and things like that. And what we need is something that can generate the lactase or beta-galactosidase, which can break down lactose. So again, when they studied the beta-lactosidase generation, they found that Clausy produces a significant amount of it. And you need to understand the intestine is in a state of controlled inflammation, and it's on the edge. So you require microbes that can maintain the redox potential. So you require to generate a lot of catalase, superoxide, dismutase, all which can bring down the things that can tilt the balance into a pro-inflammatory state. And again, you can see that Clausy, all the 4 strains generate a lot of these antioxidants to maintain the redox potential. This is something not talked about. Today, when you find a lot of children getting hair loss, what we used to call as telogen effluvium, after any acute illness, be it typhoid, be it malaria, be it after an admission, we used to only think about a condition called telogen effluvium. We used to tell them, haan, wapas aa jayega. But now we know it's probably dysbiosis. What is meant by dysbiosis is there is an alteration in the number of organisms in your gut. There is a pathobiont bloom and an alteration in the metabolites in your gut. So when there is an alteration, one very key element that you require for sustenance or for hair growth, which every dermatologist gives you, is biotin. I'm not talking about minoxidil, because minoxidil is very much in the news again now because of the werewolf babies in mothers who have used it for hair loss. So there is a little bit of transplacental transfer. So it's biotin. And that is why when you discharge them home, it's worthwhile using biotin for a short period of time to prevent this telogen effluvium or to treat the telogen effluvium. Another thing that comes out is riboflavin. So when you have the right microbes in your gut, riboflavin is something which is not generated in the body, and it's a very powerful immune modulator. So it brings down the inflammatory levels at the level of the gut as well as the CNS. And then now a fantastic study on riboflavin and biotin supplementation even in Parkinson's. Because neuroinflammation, gut inflammation, these are 2 things. There is a gut-brain axis. A lot of articles coming up with Parkinson's, which we are seeing, and there is a surge in Parkinson's, and this is one organism which generates a lot. And this is even beneficial for the commensals, the symbiotics that you carry. So you can generate something which is very favorable for your gut microbiome. And the last one is the short chain fatty acids. So any carbohydrate that escapes digestion, that's why what we tell you is it's time that you feed your microbes. So how do you feed your microbes? Start eating fibers. So you don't have an apple juice, but eat an apple. Have a banana, don't mix it with milk, but have a banana as it is. Have a carrot, have this thing, don't have the juice. So what happens is you are providing fibers that cannot be digested. And when they get into your large intestine, the microbes are just waiting for it. And they generate butyrates that are essential for gut integrity, all the metabolic functions. And it's not just at the level of the gut, it's even at the level of the brain, at the level of your skin. So it's gut-brain axis, gut-skin axis, gut-heart axis, gut-lung axis, and they are all bidirectional. So generating short chain fatty acids is number one today. And I think we should, because we hardly have any time. Any questions? I think I'll stop here.
Hello. Yeah, excellent talk, Dr. Sridhar. My question is relevant to the use of this probiotics.
Of?
Probiotics in the NICU. Like we may use them, but there are other babies in the NICU also. Some of the other babies also may be having central lines, and we know that germs from one baby can be carried to the other. So,
Cross.
consent you are taking for use of a probiotic in one child who has got a central line. Are there instances where these probiotics are carried from baby to baby?
Cross-contamination is known. Cross-contamination is very well known. So most of the accidents that did happen was initially with sachets, and you open a sachet, you're bound to contaminate the surroundings, and the IV lines used to get contaminated. We have had fungi mears with that. Tooth extraction and chewing onto a probiotic, we have had problems. Now there is a talk about what type of lactate is being produced by a probiotic. So you have D-lactate and the other type, the L-lactate. Preterms especially are prone to acidosis. So would you be aggravating the acidosis by giving a probiotic? But what we know for sure is the microbiome plays a significant role in the genesis of NEC. There is something called as a gamma proteobacterial bloom just before you get NEC. Surprising, C. difficile, the non-toxigenic form, if it is absent in the stool of the preterm, or you don't have a Bacteroides doré in the stool, they are more prone. TLR upgradation is a known thing. And we do know that in utero, NEC doesn't happen. It all happens after the baby is out, because in utero, you're laced with amniotic fluid. Epithelial growth factor brings down the TLR4. So they are even trying out that as amniotic fluid as wash. And we know if you want to bring down the TLR4 and bring up the TLR9, you get the right microbes along with HMO, human milk oligosaccharides. Early initiation of human milk oligosaccharides, a deficiency of DSNLT, one of the human milk oligosaccharide is linked. But when you use a probiotic, use a cocktail. Lactobacillus, bifidobacterium, streptococcus. So the lactobacillus, plenty. Even the first one was an infloran, which was lactobacillus bifidobacterium combination. But you should know that they can translocate. So you need to select your patients properly. You need to know that early initiation of feed is always there when you give a probiotic. You need to have a lab that can pick up translocation. And you should have the armamentarium to take care of an infection that has happened because of a translocation. So now we use bifido, lacto, streptococcus combination. But there are studies with even Saccharomyces.
So a non-pathogenic harmful bacteria are
No, that
important.
concept has changed, because now we even use an E. coli Nissel strain.
Okay.
We use certain enterococci, and we use a lot of streptococcus. Thermophilus is the main thing, and the others have come out from it, just like we use a salivarius for the oral cavity. So that has changed. Previously it was anything which has a pathogenic potential should not be used. Now it is screen them for all the genes that they possess, virulence genes, because you don't want them switching it on when the circumstances are not favorable.
Regarding one last question regarding the dosage, there are many applications where non-communicable illnesses are thought to be controlled with the probiotics.
Yeah, because
are we using probiotics currently in a homeopathic dosage?
No. So let me tell you one thing. We need to understand that, like Hippocrates said many years back, everything starts in the gut. But what is very essential for all of us to understand is, when you are treating any patient for whatever condition, you need to treat the patient as a whole and not just concentrate on the whole. This is something very essential, and everything is interconnected. Follow the dosings that the companies give, which is very, very essential. You can't take a Clausy, give 1/4 in the morning, you feel like giving it in the evening, give another 1/4, because the moment you open it, it's stress. Exposure to moisture, temperature, They can mutate, they can change. That's why we look at things that have a repository number where the genome has been decoded and stability has been proven. So you have to follow the manufacturer's dosing. And you have an interaction too. So you wouldn't use certain things with certain antibiotics, you space it out with certain antibiotics. So it's something. That's why Saccharomyces will be preferred if I'm treating an antibiotic-associated diarrhea, if I don't know much about the antibiogram, about the others, because it's a fungus. It's not affected.
Do all children routinely require a probiotic with the antibiotic prescription, or is there a certain subset of kids who have a previous tendency whom you would be more prone in writing down a probiotic with the next prescription?
Yeah, so like I always tell people that all questions don't have answers, but all answers have a question. So this is something that we are still working on. We have just come to the concept of eubiosis and dysbiosis. So anybody with comorbid conditions, but the other side of it is you can get translocation. So if I have multiple comorbidities, I'm going to get repeated courses of antibiotics, definitely yes. Because I know I don't want to increase the inflammatory tone at the level of the gut, which will go to all the parts of the body, because it's roomed in. From the gut, it gets to the rest, from the gullet. So we are entering into an era of probiosis. And now it's going to be called live bacterial therapeutics. So it's going to come in as drugs, not the way we are using it. And it has expanded so much that if I'm going to take somebody into a very stressful job and he has a tendency, suicidal tendency, I work on his oral microbiota. And if I find aloe prevotella rava, sounds pretty good, a deficiency of that particular organism, I know he's got a tendency to suicidal tendency. So if I have a family with Alzheimer's, I'm going to check for Porphyromonas gingivalis. I'm sure the microbiologist is getting excited with all the words I'm using. This is being linked to Alzheimer's. So you have the amyloid fraction, the beta, tau, protein, everything. There is a linkage. So we are getting into so much that now we know that we need the right numbers, we need the right people, we need to understand our enterotype, and we are coming back in the circle of life to living the natural way. Sync with the biological clock. Get up with the sun, go to sleep as it becomes dark, eat the right food, don't overeat, don't you see too much of light, and something that's very important to sync with the biological clock. And this is just one part of everything. Thank you so much.
Thank you for the wonderful insights into topic, dear speakers. Requesting you to kindly proceed to the felicitation point. Our next session is on vaccine updates. Updates in 6-in-1 ready-to-use vaccines, preterm data and data in special population, for which I would like to call our senior expert speaker, Dr. Vijay Yevle sir, and chairperson, Dr. Kamlesh Srivastav sir and Dr. Sachin Biradar sir. So let's start our session.
Can I start, Chairperson, sir? Okay. Okay, we saw a lot of talk on something which has no robust evidence or evidences in the making. I'm going to talk something on yet another talk on Sanofi platform, but where there is robust evidence and there is some data to talk about. So our talk is going to be on 6-in-1 RTU. So this 6-in-1 ready-to-use vaccine has these following 6 antigens: diphtheria, tetanus, the acellular pertussis, hepatitis B, Haemophilus B influenzae, and injectable polio, inactivated injectable polio. And as we understand, there is a preparation available which needs reconstitution, and there is yet another which is ready to use fully liquid preparation. And as the product insert mentions, it has a reasonably long shelf life of 36 months, provided it is preserved at the correct temperature. Now, making 6-in-1 is not just adding antigens together and coming out with a new product. A lot of research and trials are behind coming out with such a new preparation. So if you look at the evolution of this 6-in-1 vaccine, initially there was efficacy proven of the acellular pertussis DTP way back in 1994. Then HIP was added, then IP was added, and a tetravalent or pentavalent vaccine was made. And then finally, with the addition of the HBsAg, a hexavalent vaccine was made, which was licensed somewhere in 2012 and 13. And this 6-in-1 ready-to-use vaccine has undergone extensive development. It has been tried in different schedules because we know that these antigens are used in different schedules in different parts of the world. Like in India, we follow EPI schedule where the vaccines are given at 6, 10 and 14 weeks. We have Western world where 2, 3, 4, 2, 4, 6 month schedule is practiced. And then there are some countries which use only 2 primary doses and of course a toddler dose and a booster dose. It also has been, the data has been done in comparison with the available vaccines which have stood the test of time. So you have comparator vaccines which have been acellular pertussis, or it has also been compared with the age-old standard whole cell pertussis containing vaccine. And then as we understand, these vaccines are given with lot many other vaccines in that narrow window. This vaccine also has been tried when given with whether there is an impact on immunogenicity of this particular vaccine or antigens in this vaccine or the other concomitantly administered vaccine. So there is a lot of data on its non-interference with immunogenicity or any adverse impact on safety when used concomitantly with other vaccines. And then it also has been tried on different populations like term infants, preterm, immunocompromised, so on and so forth. So what we are going to concentrate today is we are going to look at the data in preterm infants of this ready-to-use vaccine. And I don't need to make the August gathering sitting here understand what prematurity is, but just to quickly recapitulate, anything who's born before 37 weeks is preterm. You have a huge burden. Less than 28 weeks we call extremely preterm, then we have very preterm, and then you have moderate and late preterm. These preterm, we must understand that they are at a higher risk of contracting infections, and like a term baby, they also, in fact, they deserve more than the term baby to be vaccinated in time. But unfortunately, there are a lot of myths and around vaccination of preterm baby, and the vaccination coverage of preterm is suboptimal globally. 1 out of 4 preterm deaths which occur universally or globally occurs from India. So it's all the more reason that we need to at least look into the high mortality and try what can be prevented by using vaccination, not only the 6-in-RTU, but all other vaccines which a preterm baby deserves. If you look at the magnitude of the problem, in India about 352,000 babies are born, and there are babies, preterm babies, the magnitude is about 13.6%. And in India, the number of preterm babies born is 352,000. So it's a huge number, substantial numbers are born preterm. And with the advent in the neonatal care, lot many preterm babies are surviving, and it is our duty to ensure that they are protected from vaccine preventable diseases. And we contribute substantially to mortality in preterm globally. Now, exposure to infections is especially critical in preterm and low birth weight babies because they have immature immune system. So their natural ability to respond or fight infection is suboptimal as compared to a term baby, and there is inadequate protection that is passively derived from the mothers in preterm babies as compared to the term baby, because we know that maximum transfer occurs in the last few weeks of gestation. Now, what are the myths around preterm vaccination? There is a lot of doubt in the healthcare provider's mind that the parents may not accept, the baby may not accept the vaccine. So there is a delay as everybody feels that the baby is weak and fragile, and if you look at the fact, scientifically and immunologically, these babies have an immune response which is equivalent to that one finds in the term baby. What about effectiveness? There is a myth that the effectiveness would be suboptimal or inadequate if a preterm baby is vaccinated at the chronological age. No, there is ample data and evidence to say that the response is adequate, and that translates into protection also. Adverse events are more common in preterm is a general feeling amongst the healthcare provider, whereas there is not much difference in terms of adverse events when it comes to preterm or term babies. Administration of multiple vaccines. Would a preterm baby tolerate so many antigens? Yes, the human body is capable of tolerating many antigens in one go, and the ability is same whether it is a term infant or a preterm infant. And lot of these preterms have associated comorbidities, and there is a feeling that these comorbidities may interfere with immune response and the child may not get the desired protection. But that's again a myth, and the comorbidities which are relevant and true in terms of vaccination of a term are no different than what exists in a preterm baby. So preterm vaccination, there is lower immune response for some antigens. However, there is a belief that there is no safety data, but if you look at the evolution of different vaccines over a period of time, it has been proven beyond doubt that the preterm babies are capable of mounting an adequate immune response, and the antigens or the vaccines are safe. There is always a fear of apnea when these babies are administered vaccine, especially the pertussis containing vaccine. But we know that the science has advanced so much that we have now acellular pertussis containing vaccines, which when administered to a preterm babies are safer in terms of adverse reaction as compared to your whole cell pertussis containing vaccine. And then this risk of apnea is more commonly seen in extremely low preterm babies who are below 28 weeks of age. However, one must take care that once the baby is stabilized in an NICU or preterm unit, you must administer vaccine at the appropriate chronological age once the baby is stable. And it is a good practice to observe these babies in the healthcare setting once you vaccinate this baby. So it is a good practice to vaccinate these babies a day before the baby is being discharged. You prepare the baby, prepare the vaccination, provided the baby becomes age eligible to get that vaccine. And the benefit of vaccination is high in this group of infants, and we must go all out to vaccinate our preterm babies. So the points to be considered when it comes to vaccinating preemies is maturity and the birth weight, and that is what would culminate into an adequate immune response. But by and large, most of the babies, though in terms of GMCs, they may be slightly on the lower side as compared to term, it does lead to adequate seroprotection, and that translates into adequate protection against disease also. Now let us look at some data. Now this 6-in-1 ready-to-use vaccine has been tried both in the primary series as well as booster series, and the antibody response, both in terms of seroprotection and the antibody titers, they have been compared in a preterm baby and term baby. And what you see here, I don't want to go into the details because a general pediatrician generally gets bored with a lot of statistics, but suffices to say that the antibody response in a preterm baby is as good, as robust as that one gets in a term baby, both for the primary series and the booster series. So robust immune response has been observed for all antigens post-primary series and post-booster in preterm infants when compared with term infants. However, when you compare the response to hepatitis B and PRP against HIV, it is marginally low, but it does not translate into inferior protection to this preterm baby against these two diseases. What about safety? In terms of adverse events also, both for the local injection site reactions and the systemic adverse events, it is comparable. So one need not, we must bust that myth that the preterm babies are more vulnerable, and the incidence of adverse effect or side effects is more in preterm baby as compared to term baby. In fact, if you look at the data in adverse effect between acellular pertussis containing vaccine and the whole cell pertussis containing vaccine, in terms of severity, they are much less in number and severity when you use a acellular pertussis containing vaccine. And by age also, lower the age, lower the maturity, more are the adverse events. Now let us look at the data on the effect of maternal antibodies, because many countries, especially in the Western world, they have adopted routine vaccination of pregnant women so as to protect the age-ineligible newborn babies against certain diseases. The important being the Tdap vaccine. Now, there is a data which has looked at the antibody titers and seroprotection in preterm babies who have been born to mothers who have received their Tdap vaccine versus mothers who are not vaccinated against Tdap. And again, the antibody titers are comparable. So the maternal antibodies do not interfere with immune response even in preterm baby. Now let us look at some data on HIV, because as I said in the beginning, we want to focus on the availability of data in this special situation, preterm babies, mothers who have received vaccination with the same antigen, where there is a passive transfer of antibodies. And in the first two instances, we saw there is the antibody titers and the seroprotection is comparable. Now look at data in HIV infants. So in general, the immunity of the vaccine may be reduced by immunosuppressive treatment or the inherent immunodeficiency. However, individuals with chronic immunodeficiency, such as HIV, and the vaccination is recommended even if the antibody response is limited. Again, there is a very good data on comparing the immunogenicity in HIV infected versus HIV uninfected, both in the primary series and the booster series. So there is ample data to say that the seroprotection and the antibody titers are adequate even in babies who are HIV infected or who have immunodeficiency. In fact, these are the babies who need to be protected and urgent and equally protected as your uninfected or term babies. Now, to summarize that, even in immunodeficient babies, the 6-in-1 ready-to-use liquid vaccine has been found to be immunogenic. Now, if you look at the adverse effect, the commonly found side effects in HIV-infected baby was tenderness at the site of injection and excessive abnormal crying. But it wasn't like the one that you get with the wholesale pertussis vaccine. Now, a special tip about the longevity of protection against hepatitis B. There are countries like South Africa which does not practice birth dose of hepatitis B. So the persistence of immune response against hepatitis B was studied in these two population, where in one series there was 3 primary shots without hepatitis B at birth, and then there was 2 primary series with no hepatitis at birth. And if you look at the persistence of seroprotection over a long period of, that is 6 years and 9 years, you see a very good protection which is long lasting. So regardless of whether you are given hepatitis B at birth or no, there is persistence. Of course, this is irrelevant in our kind of setup because we do give hepatitis B. Ours is a country which practices hepatitis B at birth. But let's not forget that there is a data to say that nearly 30 to 40% of babies who are born even in institution do not get their burdens of hepatitis B in first 24 hours of life. Now, this is yet another data set where they have looked at the response to hepatitis B antigen in this ready-to-use 6-in-1 liquid vaccine, where the comparator was wholesale pertussis hexavalent vaccine and the acellular pertussis hexavalent vaccine, and that is with and without hepatitis B at birth. And the antibody titers achieved are more than adequate, both in terms of seroprotection. The percentage of children seroconverting is very high, and the GMC is also comparable. So, it is attributed to the special yeast system that is used for hepatitis B antigen in the 6-1 ready-to-use liquid vaccine. And it has proven immunization in Indian infants also. And I must say here that no vaccine is allowed to be marketed and used in our country unless the vaccines undergo country-specific trial and they have immunogenicity or efficacy data which is generated in our country. How long would this antibody last? Because there is always a question put across in terms of longevity of protection when one uses acellular pertussis containing DPT vaccine. Let us not forget that whether you have natural disease or whether you use wholesale pertussis vaccine or acellular pertussis, immunity is not lifelong. It wanes. And what is required for sustained and adequate protection is high coverage. However, if you look at the antibodies or seroprotection over the period of time, this is a table which talks about seroprotection 4.5 years after the primary series and the toddler booster. And almost 85 to 90% and in some cases even 100% seroprotection has been seen with this antigen. So suffices to say that if you complete the primary series with a toddler dose, until the child is of school age, ready to receive the second booster, the seroprotection is adequate. Now, does this seroprotection and immunogenicity data translate into real world effectiveness? So I'm going to show you two examples or two studies. Mexico, they have generated data for 2 decades, between 2000 and 2019. This is a retrospective surveillance data. Mexico started using acellular pertussis DPT containing vaccine from year 2007. So until 2007, the children received wholesale pertussis and later on they received acellular pertussis. They used 3 doses in primary schedule, 2, 4, 6 months. And when they were using wholesale pertussis, the booster was given at 24 months. And when they switched over to acellular pertussis, the booster was given at 18 months. And they introduced PCR for making a diagnosis of pertussis in year 2012. And they also started maternal Tdap immunization from year 2014. And they looked at 3 parameters: the incidence rate of pertussis, the vaccine coverage, and the vaccine effectiveness. Vaccine effectiveness in children between 6 months to 48 months, and compared both those who received wholesale pertussis vaccine and those who received acellular pertussis vaccine. And what they found was there was a steady increase in the incidence of pertussis, but this was seen across, and there was a correlation with vaccine coverage. And the years 2012, 15 and 16, they recorded high incidence of pertussis. So one, PCR was used as a modality to diagnose pertussis. There was dip in vaccination coverage. And if you analyze the vaccine effectiveness between the acellular pertussis and wholesale pertussis vaccine, it was comparable. So they looked at the WP and AP vaccine effectiveness estimates with 3 doses versus no vaccination in children who had not received the toddler dose, and then in children who received the primary series as well as the first booster dose. And the vaccine effectiveness of 3-dose primary series was comparable whether the child received wholesale pertussis or acellular pertussis, and even following a booster dose, the effectiveness. So this is the real world impact. The effectiveness was unaltered whether the children receive wholesale pertussis or acellular pertussis containing vaccine. Now, I'm highlighting this because a lot of misconception prevails in the minds of pediatricians that if you use acellular pertussis vaccine, what you're offering is an inferior vaccine to a child. No, for disease control, what is important is vaccination coverage, and especially for pertussis control, what you need is very high level of sustained vaccination coverage. At the same time, let me also make it very clear, those who are using wholesale pertussis vaccine and the parents who are comfortable accepting that wholesale pertussis with minimal local reaction or systemic reaction, one need not really change the practice. But not to forget that let that adverse effect of whole cell pertussis come in the way of vaccine uptake and vaccine coverage. So the message from the Mexico study is there is increasing trend in pertussis, especially after they started using PCR as a diagnostic modality. More than 96% vaccine effectiveness was demonstrated, whether children were used vaccinated with whole cell pertussis containing combination vaccine or acellular pertussis vaccine, and the replacement of acellular pertussis did not lead to the increase in the case of pertussis. This is second data which talks about the vaccine waning of the antibodies following pertussis vaccine, DPT vaccine, in Polish children. These children received primary series as either whole cell or acellular pertussis vaccine, and the booster was with acellular pertussis vaccine. And they look at the antibody kinetics, and both children who had received whole cell pertussis and the children who received acellular pertussis, the vaccine waning was almost overlapping. So we understand again, and this is a proof to say that whether you use whole cell pertussis or acellular pertussis DPT vaccine, the antibodies wane, and what is required is repeated boosting. Now, concomitant administration, again there is no immunointerference. Can it be used with other vaccines? Yes. When you use it with other vaccines, use a separate syringe, it can be given on the same day. So benefits of full liquid vaccine, one is it's in terms of time, it's time saving. Of course, I mean, this is a relative phenomena. If you look at the vaccine which needs reconstitution, it would require a little more time. And then when you need to reconstitute a vaccine, there is always a risk of error. And these are the common errors which have been pointed out in a study which was carried out in Belgium. They compared healthcare providers, making reconstitutable vaccine and, filling the ready-to-use liquid vaccine. And then finger touching the nozzle of the syringe, or needle getting twisted while puncturing the cap of the vial of the lyophilized powder, inadvertently using the same needle leading to a more painful experience in the vaccinee, or while purging, either withdrawing inadequate volume, or expressing or purging a little more volume. All these common errors were observed in this study, and the errors were much less when a ready-to-use liquid vaccine was used. The preparation price was 50%, and the errors, this common errors, were 5 times less when ready-to-use vaccines was used. So more emphasis on the reduction of human errors should be made, and both in terms of reduction in time and reduction in errors. So to summarize, this ready-to-use liquid vaccine, which contains acellular pertussis, has ample data on its immunogenicity, seroprotection, longevity. It is quicker, safer, and precise. And this benefit should be passed on to children, to the parents, to the doctors and nurses. And ultimately, we must aim of achieving vaccination of all the children where immunization is their birthright, and we should try and improve vaccination coverage. And I would end saying that use whatever vaccine you want to use, but ensure that children get a comfortable experience when they come to you. Please do not hesitate to use a less reactogenic acellular pertussis containing vaccine when it comes to practice. Let's come out of that myth that acellular pertussis vaccines are inferior to whole cell pertussis vaccine. Thank you.
Hello. Thank you for informative talk. I would like to ask one question. It is weight of the infant is important, or the maturity is important?
No, when it comes to immunotherapy, you need to take into consideration both the weight and maturity.
So, infant born of 1 kg, and he could not attend, suppose 2 kg or 2.5 kg at the 1.5 month. So at that time, should we give hepatitis B vaccine or should we not?
So you should give all the antigens once the preterm baby is stable. Babies who do not who are not 2 kg or less, there was a study done in the past where it was found that the hepatitis B antibody response was suboptimal. However, what was recommended then was vaccinate this baby and don't count that dose and give 3 additional doses. And in today's era, as such, we are using 0 dose of hepatitis B plus at 6, 10, 14 weeks as a combination, we use 3 additional doses of hepatitis B. So that recommendation of not to use hepatitis B, vaccine in babies who are born preterm no longer is valid. Why? 0 dose, 6, 10, 14. Yeah. So that is what I'm saying. That should not happen. Though there was the.
But then you are saying that it can be done. So, or you directly wait for another 15 days.
You don't have to, I'm saying you don't have to wait. Regardless of the weight and the prematurity or maturity, the moment the preterm baby is stable, give the 0 dose of hepatitis B. Because as such, you're going to follow it up with 3 additional doses.
Yeah, but that will get, my point is that then you will have to keep a gap of 3 to 4 weeks na, for the next dose.
Not necessarily.
Why?
Why
You don't count that.
You
make
don't
it zero.
count that. You give your combination except at 6 weeks of age.
This question is related to a subset of the preterm babies who are very extreme preterm and very
Yes.
very low birth weight. Now, for example, baby born at 26 weeker, and obviously such extreme preterm baby will have a lot many medical problems, and baby is still in the NICU at 6 weeks, which comes to somewhere around 32 weeks.
Correct.
The baby is still having, for example, a fungal infection or some secondary nosocomial infection, who is not in life support system, but he is kind of continue to get an antimicrobial agents to recover from the primary infection. Should we give this vaccine?
So, use of simultaneous antimicrobial agent is not a contraindication. The moment is of oxygen support, baby is off oxygen support and stable, you can jolly well use the vaccine at 6 weeks of
There are
age.
few babies who are on oxygen support because of the primary BPD.
Then one would wait until
So
the baby
when we
is.
say stable, which means not stable in terms of what? For example, there are so many babies who are on BPD, goes on home oxygen. Should they be
So-
getting the vaccine?
Only little oxygen where the baby is given home oxygen therapy for BPD is no contraindication to start vaccination at chronological age. You can vaccinate these babies.
And would
And it is better to vaccinate them in healthcare setup because the risk of apnea is higher in preterm baby as compared to term babies. I would vaccinate even a baby of CPD, BPD who goes home on oxygen at 6 weeks of life.
okay. And as compared to the hepatitis B, what we were just talking, if the baby still has not attained, for example, a certain weight, and at 32 week or 34 week, baby is still somewhere around 1.2 kilo, 1.4 kilo. Should we count this as still a first dose, or we discount that as a
So
zero
if
dose?
the baby is chronologically 6 weeks,
6 weeks.
you would directly give the combination vaccine and count that.
Count
dose.
that as a first dose.
Yes, definitely.
And
Yes, Sadiq.
No, I think as far as I know, 0 dose is not studied in extreme preterm babies. So although
is
you
not
said, so it's
Yeah.
not studied. So it doesn't look, there is no recommendation to give 0 dose. 0 dose is Indian Zugad for OP. So OPV, of course, you will not give 0 dose oral polio in neonatal nurseries. No, because it can spread to other babies. Similarly, there is no real recommendation for 0 dose hepatitis. We totally agree with your other statement that 1.5 months, irrespective of the weight, once the child is stable, we should give. But I think 0 dose we need to study whether there is a recommendation or
So
not.
by 0 dose, you mean the birth dose of
A
hepatitis
dose of
B?
hepatitis B within 24 hours as soon as.
I agree with that. Birth dose should be given as soon as possible, preferably within 24 hours. So in the past, they found that babies who were less than 2 kg, the antibody response was suboptimal. But what I'm saying is preterm baby who is chronologically 6 weeks, you don't give the birth dose, you give the combination
Absolutely,
vaccine.
that's what
Yeah,
I'm saying. Don't give
absolutely.
birth dose. So
Yes.
birth dose is not recommended.
And in the past also, babies who were less than 2 kg, the recommendation was to wait for 28 days. Here the baby is 6 weeks.
Okay.
So you give your first dose combination vaccine.
And which means that we probably also will be missing the rotaviral oral vaccine at 6 weeks. Baby is still
So
in the
rotavirus
NICU.
vaccine, there are two schools of thought. In some nurseries, they say if you are able to handle the excreta and observe those aseptic precaution and keep your very sick babies away from the bassinet where this baby is kept, you can give rotavirus vaccine. But by and large, the recommendation is not to use rotavirus vaccine and oral polio while the baby is a sick baby or preterm baby is in the nursery.